Hi guys, let's discuss about idiopathic thrombocytopenic purpura today. So, idiopathic thrombocytopenic purpura is an immune-mediated bleeding disorder. This is most commonly seen in pediatric age group between 1 to 7 years of age. So, we know as the name suggests idiopathic, but we have some immune etiology. So, it's one of the immune-mediated disorder. So, we have two types of idiopathic thrombocytopenic purpura, which is an acute and chronic. Acute is which has less than 6 months of thrombocytopenia. Chronic is more than 6 months of thrombocytopenia. Children will develop only acute idiopathic thrombocytopenic purpura, and even that has a spontaneous resolution by 2 to 4 months of diagnosis, even without therapy also. So let's know about the pathogenesis of idiopathic thrombocytopenic purpura. In idiopathic thrombocytopenic purpura, there is some immune etiology where antibodies are targeted against some of the surface glycoproteins like glycoprotein 1b9 and mainly glycoprotein 2b3a. So these autoantibodies get coated on the surface of the platelets, and when these platelets go to the spleen, and this antibody coated platelets are recognized by the macrophages and they undergo phagocytosis, leading to destruction of the platelets, leading to thrombocytopenia. So this is one of the quantitative platelet disorder. Coming to the clinical features, we have usually children will develop after an episode of febrile viral illness. So this will one of the prominent antecedent history will be present of febrile illness, and due to less number of platelets, the child may develop some bruises and mucosal bleeding and epistaxis as you can see in the image, and oral oozings and prolonged bleeding even for a minor trauma. These are some of the clinical features, but we have to know when the patient will develop bleeding. Bleeding will develop only when the platelet count goes below to 20,000 per microliter. Whereas if it is around somewhere around 20,000 to 50,000, it will just cause petechiae and ecchymosis and there will not be any frank bleeding. And how can we diagnose laboratorically? Here we'll do a complete blood count. Now, no parameters will have any changes. Only the number of platelet count will be diminished. If we do a peripheral smear, we may get some blast cells if malarial parasites can be seen, and we can also get to know the platelet count. And main important is this platelet size, where we can see this large giant platelets. This comes into the peripheral smear because of accelerated megakaryopoiesis due to the destruction of the platelets. Then we can do LFT, RFT to rule out other hepatitis, hemolytic uremic syndrome, and chest X-ray can be done to rule out any other causes for febrile illness, and blood culture can be given. Then tests for malaria and dengue, some of the DDs for thrombocytopenia can also be done. When we do a bone marrow study, it shows increased production of megakaryocytes. This is the laboratory findings of idiopathic thrombocytopenic purpura. Coming to the management, as I have already told, many children does not require management. Only thing is we have to minimize the risk of hemorrhage, avoid trauma, all those things. If the platelet count is above 20,000 and there is no frank bleeding, then just observation is enough. If the child presents with bleeding, then the treatment will be IVIG, intravenous immunoglobulin, 1 gram per kg per day for 1 to 2 days can be given. And if the child is Rh positive child, we can also give anti-D immunoglobulin 50 to 75 mg per kg. And steroids are tried like dexamethasone 20 mg per meter square for 4 days every 3 weeks, around 4 to 6 course, or prednisolone can be given for 2 to 3 weeks. If there is only serious hemorrhage, then platelet transfusion is considered. This is so for mainly acute ITP, transfusion is not required. For chronic ITP in adults, low dose steroids, splenectomy, danazole, vincristine, cyclosporin, azathioprine, and rituximab can be tried. This is all we have to know about idiopathic thrombocytopenic purpura. Thank you for listening.